awesome. Thank you for that information. And then what teaching do you provide? Obviously, a lot of family and caregiver training is involved. So what do you what do you need to focus on with training?
We do. I teach them home exercise programs. A lot of our babies get real tight from laying in a in a non intrauterine water-based environment where they get all the skills they're supposed to, so they're in a very flattened space, so they get real stiff. So I teach the parents how to do massage and how to do some stretching. A lot of our babies have, pretty much all of them, and across the United States in NICUs have a right-sided head preference. We're not sure why. And so they start to develop some flattening on that side of the neck and can develop like a pre-torticollis, so their neck muscles get tight. So I show the parents how to stretch the neck, what to look at with head shape, how to interact appropriately for the baby's developmental state. You know, when we pick up babies, we often want to start talking to them and cooing and rocking and moving, and for these preemies, they can't handle that. So I have to teach the parents, what is the best way to interact with their baby to not put them into a stress state. As the baby gets closer to going home, and then if the parents want to come every time and observe a treatment, they can. Oftentimes, we don't have as many parents visit during the day or even at all in our NICU as some. But if they would like to, towards the end of the baby's stay, we do what's called discharge teaching. So I talk about tummy time, I talk about adjustment for prematurity, and I talk about developmentally appropriate toys, concerns, what to look for with head shape, and safe sleep, which is using the sleep sacks to go to sleep instead of swaddling.
Great, and we're also talking about discharge. In addition to education, what other roles do you play specifically in discharge planning?
We make the recommendations whether the baby's going to need further services, whether it's outpatient services or early intervention, and then if they are born prior to 28 weeks, they qualify for neonatal follow-up clinic, and that's where they come in at 1 month, 3 months, 6 months, 12 months, I believe 9 months if there's a concern in there. And we follow their development to make sure they're coming along as should with the developmental skills and that there aren't any big concerns, or if we have concerns, we're getting them the appropriate therapies. So when they are discharged, our therapy team, and myself included, makes the call to the appropriate early intervention center. Every county has their own, so we look at the address, and then from there we just make the referral and make sure that that baby within 2 to 3 weeks gets a phone call, that family gets a phone call from the appropriate sources from early intervention to set up therapy. But there can be a 1 to 2 month gap there, so then what we do is sometimes prescribe some outpatient physical and occupational therapy if we're worried the baby's going to get worse in the meantime.
Great, and can you talk a little bit about goal writing too? What kind of goals are you writing? How many goals usually do you try to develop per client?
Generally, I mean, it depends on the baby, but we usually have short-term goals, which if I start treating the baby at 32 weeks, our short-term goals are usually about 3 to 4 weeks in length. Our long-term goals are about 6 or 7 weeks in length, bringing them to about 40 weeks gestation. The goals include looking at random movements initially, because these infants have very little movement when we start working with them. Gravity's pushing down on them. They lack the muscle strength and tone to be able to move against that and come to what we say is coming to midline. So just to get them to randomly move, that's going to be one goal with our facilitation. Another one is going to be approaching midline, and that's important for a lot of reasons. Obviously, we want that scapula to get in the right position, but we also want to facilitate some self-calming skills. We look at head turning because that's very important. If they're always coming to the right, we want to make sure they're able to turn their head both ways. Another goal would be reciprocal kicking, which is like I just talked about earlier. That's the moving the legs separately, which is really important. Head writing in supported sitting, visual contact, visual regard, and visual tracking is another goal. For some babies, it's like our babies who are what we say NAS, who have neonatal abstinence syndrome, who are very, very, very crabby and hyper alert to everything. Then we're looking for them to have appropriate calming skills to the input that we're giving them. And then obviously there's different goals based on different orthopedic and splinting. If we need to do splinting, there's some splinting goals.
Great. And then who exactly is on a typical care team in the NICU? Yourself, the physical therapist, and then who else would that be comprised of?
The speech therapist, and they come in around 33 weeks if needed. Some babies, our nurses are very competent in feeding. In this NICU at Loyola, the OT does not do feeding. It is common in many NICUs that they do feeding. The neonatal ICU I worked at in Wisconsin, we as OTs did the feeding. So there's the speech therapist, the physical therapist, the occupational therapist. There's dietitian who works on caloric needs and weight gain. There is pharmacy who works on all the medications, and then nursing and physicians, and then specialists come in as far as specialty physicians when there's certain needs like GI, pulmonary, neurosurgery, or orthopedics.
Great. And what are some challenges that you feel are present in this setting in your role as an occupational therapist? What are some things that you come across that are obstacles or that provide challenges in your practice?
I think the most challenging thing is if you have a team that doesn't want to work well with you. The nurses really know these babies well. They've been doing it a long time. It can be a bit of a challenge when you enter that setting to get them to know that you're all in it together. That was a bit of a challenge for me, getting to the nurses to understand that we all have the baby's best interests at heart, and now we get along fantastically. I guess carry through, there's nurses during the day shift and afternoon and night, so I might put in some wonderful positioning devices for an infant in place, and or some safe sleep, halo sleep sacks as they get bigger, and then even though I put it in a nursing order so it carries through, maybe it might not carry through to the next day. The other challenge would just be the social family situation. Sometimes I don't get to meet with parents because they're working and or other social situations where there's not a lot of parent interest. So that's a little frustrating because we can do everything in the world, but if their parents aren't coming in to have good carryover, that can be problematic. It's a very highly specialized population, so it's an area that if any of your you guys as students are interested in, I highly recommend trying to observe a little bit, because generally it will be difficult to get a new graduate position right out of school, so that can be a little frustrating, because I remember as a new grad that was my dream, was to be a neonatal therapist, but it took a lot of years of pediatrics and inpatient peds and outpatient peds to get that under my belt before, to understand infant and typical infant development prior to then going into the preemie world.
That's great. And then what do you love about this setting?
Everything.
Yeah.
No, I really love the fact that these infants come in and they're so tiny and so fragile, and you get to see them grow and turn into really happy, bubbly, chunky babies. Whether at the end when they leave they're at that point or maybe not, but then they come back and visit. I guess the most rewarding thing is that you can sometimes think, because a baby may have had a big bleed in their head, so you might be thinking, and based on their muscle tone or lack of movement, that they're going to have permanent deficits, and then over time they prove you wrong, because that neuroplasticity in infants is pretty profound. So sometimes you can have one idea in your head that you think there's going to be some difficulties for this child for the rest of their life or down the road, and in fact it comes back the opposite. So it's been very rewarding, and I love babies, so the other bonuses is you get to snuggle babies a lot.
That's great. Is there anything else you want the students to know about working in the NICU before we conclude?
No, it's a fantastic area. Like I said, I would encourage you, if you have a very strong interest, to start doing some observation hours, and go to courses and learn as much as you can about infant development prior to getting into preemie development.
Thanks, Allison.
You're welcome.
This was enlightening and fascinating, and I'm sure all the students are going to appreciate your experience and expertise.
You're welcome.
Thanks.
Thank you.